Just so you all know, we will be recording this event. But thank you for joining us and giving your morning to us to hear about some new and exciting opportunities out there for treatment. So my name is Stephanie Freeman. I'm the Memory Center Program Coordinator here at Norton Neuroscience Institute. And I'm, again, so glad to be here with you guys today and joined by some awesome colleagues. We are recording this for future use, and we will be posting this in our video library so you all can access this at a later date. I want to put notifications or notes or bring you to the Q&A box and the chat box, but specifically the Q&A box. Go ahead and ask your questions of our guest speakers so we can get those to you at the very end of the presentations. And we will answer those live on here as well. So first, I'm going to have Erin Gillespie with the Alzheimer's Association. She is the Director of Programs for the Alzheimer's Association, Greater Kentucky and Southern Indiana chapter. So we are excited she is here to share her resources. So Erin, go ahead and take it away.
Absolutely. Thank you, Stephanie. And I am going to share my PowerPoint. Again, thank you for this opportunity. I look forward to presenting some of the resources and the information that the Alzheimer's Association has, and in partnership with so many great organizations in the community like Norton Neuroscience, we have the opportunity to provide a robust opportunity for caregivers and then also those living with the disease. At the Alzheimer's Association, our mission as the association leads the way to end Alzheimer's and all other dementias by accelerating global research, risk reduction, early detection, and maximizing quality care and support. So every year, our organization comes out with something called the Facts and Figures. This is statistics about Alzheimer's prevalence, caregiving, and the cost of care in, across the nation. And I'll be transparent. This was a little wonky earlier, so we will see if it works. Can you all see that? So
watch what 2024 chicken does to your belly.
Sorry, you all. I knew that was going to happen. My apologies.
2023. You tell the difference if you compare a chicken.
All right, we'll try this again. I apologize. We did practice, I promise, but best laid plans, right? So again, you can see these facts and figures on our website if you go to alz.org facts. And so again, this is just an annual report that the Alzheimer's Association puts out, and we do have state-specific statistics as well. And I'm not going to go over this whole spreadsheet. There's a lot of numbers. We are happy to share this after the program. But some things that I would like to highlight, I know this series is called The Capable Caregiver. And so as you will see here, caregiving can have an impact on someone's health. Caregivers in Kentucky, over 65% have chronic health conditions. Almost 40% have depression. And, there's over 150,000 caregivers here in Kentucky today. And I'll also highlight that this is a number that are reported. So we know that there's a lot more caregivers out there, and we know that there's a lot more people affected by Alzheimer's. Almost 7 million Americans today. So as we talk about caregiving, there are unique challenges for people that care for individuals with dementia and Alzheimer's. Dementia caregivers have twice the average of out-of-pocket caregiving cost. 30 to 40% of dementia caregivers experience depression. 44% of caregivers have anxiety. And the majority of these experiences are by women, because we know that 2/3 of people living with Alzheimer's are women, and also 60% of all caregivers are women. I tell you these things not to detour you or to upset you in any way as a caregiver, but this is the reason that we talk about these statistics and how it's going to impact your life, so you can reach out for that support that you need. We do have an Alzheimer's Association 24/7 helpline. I'll talk a little bit about that later today. This is 24/7, day or night. Any challenges that you have, please call this number. We are here to support you, and that support you will see reduces anxieties, gets you plugged into people that get it. We also talk a little bit about taking care of yourself, making sure you're going to the doctor regularly. You know, when you get on an airplane, they talk about, making sure that you put on your mask before the person beside you. This is the same thing when it comes to caregiving. If you're not taking care of yourself, you can't take care of your loved one. So making sure you're eating well, exercising, getting plenty of rest, take a break whenever you can. It's okay to go out with a friend and go to coffee, take a walk around the block. This time for yourself is very important for your mental and your physical health. So again, you saw the impact that it has on caregivers, what you need to do to help. There's so much information out there to support you and your loved one. And so these are just some of the things that the Alzheimer's Association provides. We do cover 125 counties in Southern Indiana and in Kentucky. We offer online resources and support. We know caregiving, you may not be able to step out in the middle of the day if your loved one's having a bad day, or your agenda is packed with doctor's visits, or if you just need some rest that day. So we do offer all of our resources online. Again, our 24/7 helpline. Not too long ago, somebody asked me, they were like, well, I thought this was, just for emergencies. Absolutely not. If you're just having a bad day and it's 2 o'clock in the morning and you can't sleep, you can call this number. If you need more information about how do I get a POA, I know it's important, but I don't know the processes. I don't know who to contact. You can call this number. So again, this is to help you. This is by our organization. I know it's a 1-800 number, so it's not contracted to a third party. Again, this is a arm of our organization, and they are there to help support you at any time. We have support groups, education programs, advocacy, and of course, our Walk to End Alls. This, I will be very honest, this slide is pretty busy because we do have a lot of resources for, again, you as a caregiver and those living with the disease. But right now, I'll just highlight a few. Here at the bottom, you will see our community resource finder. We know that people live all over the state of Kentucky, or you may be a caregiver and you have someone that's living in another state. All of our organizations, resources, where to find a medical center, all the way to where to find a support group can be found on our community resource finder through zip code. I used to live in Louisville, and I know that if I was looking for something on the East End and I just Googled it, it may take me all the way over to the West End. And so it's really important to have those resources close to you so you don't have to travel a lot. And also, of course, your time is significant when you're trying to find resources and information. You can also go to our website. I'll show you a little bit about that at alz.org/KYIN. These are localized resources, and then also our national resources. Two I wanted to highlight that were on the previous slide, but this kind of gives you a clearer view. All's Connected is an online community for people with Alzheimer's, caregivers, family or friends, neighbors. It's just an opportunity to discuss and to communicate with other people that get it. Maybe you're just wanting to know more about it, or maybe you're newly diagnosed, or you're newly a caregiver and you just want to see what other people have been through. And this gives you the opportunity to really be around people that get it. Our Alls Navigator, both of these have been recently updated, and I'm a big fan of the Alls Navigator. You know, a lot of times people come to us and just don't know what to do next, or they're in a specific situation like, I don't know if my loved one should be driving anymore. What are the signs? What are some tips and strategies? The Alls Navigator is an interactive tool. You plug in the topic and then answer a few questions that are specific to your situation, and it spits out a care-related like action plan specific to your needs. And all these, again, are online. We know that caregivers need a lot of support, and there's different phases of caregiving. And so our caregiver support, it's online and it's help. You can see the website below. And again, Stephanie said this will be sent out afterward. But what to expect? A lot of people, every person with dementia, if you met one, you've met one. And so this gives you the opportunity to kind of see what the cycle of this disease is and what it looks like as a caregiver. It gives you opportunities to get support, what it looks like for daily care, and then care options and planning. We know it's very important upon a diagnosis or even those early signs of cognitive impairment. Starting to get that care plan is very important for not only reducing your anxiety and stress as you move forward in navigating the disease, but also it gives the opportunity for your loved one to be part of that planning. I use this website every single day. When somebody has a question, whether it comes from financial and legal, if they're wondering, how do I keep my loved one from wondering, they're starting to get out? Is it a safety issue? What are some strategies to keep them safe? All these things can be found on our publications page, and all of them are PDFs that you can print out and you can send to your family if they need to know more about the disease. And again, this is just a robust information portal where you can print PDFs, anything from bathing to safety. So the Alzheimer's Association, we do provide, as you saw earlier, a lot of support in our communities. One thing that we have in the Louisville area, if you're not from the Louisville area, we have over 29 in the state of Kentucky and Southern Indiana. I just pulled the Louisville caregiver support groups just for your viewing, but again, you can see all these on our community resource finder. Recently, we did add a new support group. We know not every caregiver is in the same situation. Whether it's a mother and a daughter, their situations are going to look a little different than a spouse. So we do have a support group specifically for spouses. So some of that information you may not want to share in front of other different types of caregivers. This is specific to spouses and partners. It's become a huge success. It is led by a counselor and also trained by the Alzheimer's Association. And that's something I did forget to mention, is that all of our programs and our support groups, all of our facilitators are trained by us. So they are very familiar with dementia and navigating the disease. And most of them are either past caregivers or work in the aging space. So they have a lot of resources, personal experiences, and sometimes people don't think of support groups or are a little hesitant to go. But I will say support groups are also a great place to meet other people, go have coffee. I know one of our caregivers the other day was talking about how she's met so many great friends that she still has, even though her loved one has passed several years ago. And also, it's just an opportunity to learn more, learn from others, and learn from your facilitators. This is a new program that we have out. We know that grief is a process through every stage, from the beginning of seeing some changes in your loved one, from the diagnosis through the journey. And this grief process looks different for each person, whether you're the person living with the disease or if you're a spouse, a care partner, or an adult caregiver. But grief doesn't understanding how to tap into that grief is very important, and understanding what grief is as you move through this journey. So if you're interested, again, this will be sent out and it can be found on our community resource finder. Social engagement is still very, very important for your mental health as a caregiver and as a person living with a disease. So we do offer social engagement opportunities where you can go. You don't have to worry about your loved one if they're repeating themselves, or you're around. It's a safe space, and you're around people that get it. And so this is held on the second Saturday at the museum, or at the Speed Art Museum, and it's called Memories at the Museum. Again, all the people at Speed Art that facilitate this program are trained by us. But it's never too late to create those memories. And it's really important for yourself and your loved one to go out and still have fun in a comfortable way. And then also creating those new memories and spending time together. These are some of the programs that we offer. The Alzheimer's Association, we get a lot of people that come to us that have a loved one that's already diagnosed. They maybe have MCI, or maybe they have early stage, but they don't understand what it really does to the brain, or some of the behaviors that come along with the Alzheimer's, or how to communicate with them throughout the different stages. We're here to help support that and give you all the tools you need. I'll be honest, when my grandmother, I was a caregiver for my grandmother, and I would say things like, well, don't you remember? It's really hard to train your brain not to do that. But that would just aggravate her. And if I would have known some of these tips and strategies on how to communicate with her, I think it would have definitely supported me in my anxieties and stress, and her, because then I would have been able to better communicate. And, you know, um, these supports, and you can get all the education you can, but also remember to give yourself some grace. We're all human. But some of these programs can help you through those stages and understanding what to do next and best care for your loved one. And as you're here today, but I did want to remind you that we do have 2 more education programs within this series, one on May 16th. And, a lot of our caregivers do come to us, and as you saw in the statistics, they are impacted by being a caregiver. So what are the risks of developing dementia as a caregiver? And then finally, breaking down the stages of dementia. Each stage is different. Each communication strategy is different, and the behaviors that come along with those stages look different. So please join us. Again, this information will be sent to you, but we look forward to the rest of the program. And thank you again for having me here. And we hope to see you for the next 2.
Thank you, Erin. Always good to hear your resources. All right, so we will move on to Dr. Greg Cooper is going to share some new information that's out there you may have seen in the news, and help us understand these new anti-amyloid treatments. So Dr. Greg Cooper is a neurologist and the memory disorder specialist here at Norton Neuroscience Institute. So help me welcome and thank you, Dr. Cooper.
All right, thank you. Can you hear me okay? See everything okay?
Yes.
Okay,
great.
perfect. So thank you, and also thank you, Erin. Thank everyone for being here. It's really a privilege to get to be a part of a program like this, and have always valued our partnership with the Alzheimer's Association. So the topic we're going to talk about today are new therapies that are now being developed and coming on the market, anti-amyloid therapies. At times, this may feel like it gets a little bit deep into the weeds, and I don't intend for that to happen. But I think it's helpful to understand really the rationale behind these new medications, understand why they're being developed, and then really understand what the benefit is. So, well, let's see if I can. Okay. So first, as just a little bit of background, where does this idea come from? It comes from the prevailing hypothesis, the prevailing theory in Alzheimer's disease called the amyloid hypothesis. And very simply, it states that it's the deposition of beta amyloid, a protein in the brain, that then is the key trigger to everything else that we see in the long, complex cascade leading to Alzheimer's disease. And this is another way of looking at it. So with this hypothesis, at the very top, we deposit this protein called amyloid. And then that leads to synaptic dysfunction. What that really means is that the connections between nerve cells start to break down. They don't work properly. So we're not connecting, we're not communicating well. We have tau-mediated injury. Some of you have heard the term neurofibrillary tangles. That's where that comes in. And then the brain atrophies, it shrinks. Now, it has to be pointed out, for all of us, our brain is atrophying as we get older. And that doesn't necessarily mean anything, but you can have an excessive amount of atrophy. And then it's at the very end of this is the cognitive decline. So you have all of those steps that occur before we ever start seeing some of our problems with memory that if we develop Alzheimer's disease, we might see. So where does this come from? Yeah, don't need to get too bogged down in the details, but the amyloid comes from a larger protein. It's called the amyloid precursor protein. It's a highly conserved gene family, which means that it probably serves some very important functions for all of us. And some of those roles might be in development of our nervous system, how nerves and muscles connect, how synapses, those connections between nerve cells, brain cells, are formed. Dendritic complexity, that again gets into the connection between brain cells. And the last one I'll say is that synaptic function and plasticity. That's our ability to form new connections between brain cells. So bottom line, not to remember all those facts, but to know that this larger protein, the amyloid precursor protein, certainly does some important and necessary things within our brain. That's not the problem. The problem is how that protein might get broken down. So we all develop or produce proteins throughout our brains, throughout our bodies that serve normal processes, and then that gets recycled. Those get broken down and reformed. Well, for this particular protein, it's broken down by some enzymes called secretases. There's an alpha, beta, and gamma secretase. And if it's the alpha secretase that is at play here, that releases a fragment, the S in there stands for soluble, that seems to be good. It's neuroprotective, it's neurotrophic, it helps protect our neurons. But if the processing goes through another channel, the beta secretase, that leads to A beta or beta amyloid, the bad protein that we don't like. And here's a better way of looking at it. So if you look at that sort of large, almost looks like a tube in the very center, that's our amyloid precursor protein. And this is the way it may look in a cell. The golden part is within the cell. These sort of balls and squiggly lines are the membrane around our cell. And then the protein extends outside of the cell. Again, that's normal. If we go to the left, that's where the alpha secretase, this one enzyme, cleaves or breaks down that protein. And that essentially leads to good things. This SAPP alpha is the one that's neuroprotective, neurotrophic in some way. So we like that. But let's say instead it's cut by the other enzyme, the beta secretase. That eventually leads all the way to this right side, the A beta or beta amyloid. And that's what we think starts leading to some of the negative changes we see in Alzheimer's disease. Here's another way of looking at it. I think, at least for me, a little easier way to look at it. In the top panel, again, we have these long squiggly lines. Those are the normal protein, the amyloid precursor protein. And then down here in that bottom left-hand corner are where these enzymes start to break that apart. And if they break it apart in a particular way, it releases that golden fragment. That's the beta amyloid. Now, that is happening to all of us right now, and that's okay. If it happens in a small enough amount, our body can deal with that. It clears it out of the way. It's not a problem. But if it starts to accumulate too much, either we produce too much of it or we're not clearing it out of the way, then it starts to clump together. And that's what you see in this bottom right-hand figure. You start to form these beta amyloid plaques. And again, that's where we really think there are problems. Well, so what's the evidence to say that this is true? Well, we've got evidence pathologically, genetically, looking at biomarkers, and we'll go through all of that just very briefly. So we've known for 100 years now, if we look under the microscope at the brain of someone with Alzheimer's disease, we see two things, plaques and tangles. The plaques, which you see over here to the left-hand side, are made up of this beta amyloid or amyloid beta protein. So that tells us that amyloid is somehow involved in this disease. The tangles are where we see that tau pathology, and that we think occurs downstream, but we think the first step is formation of these plaques. So just from the pathology, just from looking under the microscope, that's some evidence that amyloid must be involved. And there's a lot of evidence from genetics. Now, the majority of people are not affected by these first items I listed, but it still gives us a lot of important information. There are genetic conditions that if I have one of these, I will develop Alzheimer's disease if I live long enough. Those are what are called autosomal dominant mutations. That's less than 1% of people. It's a small number, but it's still important because every one of those mutations, if I carry it, involves amyloid or the production of beta amyloid. So we have a lot of evidence then that certain genetic mutations can lead to too much amyloid and lead to Alzheimer's disease. Down syndrome is another one. In Down syndrome, we have an extra copy of chromosome 21. It just so happens that the amyloid precursor protein gene is on chromosome 21. So individuals with Down syndrome develop too much of the amyloid precursor protein, and we think in that way are prone to develop amyloid plaques. And essentially, everyone with Down syndrome, if they live long enough, if they live into their 50s, they will develop Alzheimer's disease. So again, that's pretty strong evidence. And then the strongest gene risk factor is the apolipoprotein E or ApoE gene, and a specific variant of that, the E4. Now, we all have two copies of this gene, and it may be a combination of an E2 and an E4, an E3 and an E4, an E2 and E3, some combination. It is known that if we have one, or even more so if we have two copies of that E4, sometimes called epsilon 4 allele or gene, we have a greater risk of developing Alzheimer's disease. It does not mean we will develop Alzheimer's disease, but it means we have a higher risk. And that also seems to be associated with more of this A beta or amyloid beta. So all of these genetic conditions that either give us or put us at higher risk for Alzheimer's disease seem to work by increasing levels of amyloid. Now, just the opposite. Several years ago now, a mutation was identified in Iceland. It's a mutation of the amyloid precursor protein, APP, and this mutation reduces the formation of A beta, or beta amyloid, by about 40%. It blocks that enzyme, the beta secretase, and so we don't form that bad amyloid. Not only is that mutation protective against Alzheimer's disease, really intriguingly, it is protective against the normal cognitive decline that is often associated with aging. So again, another piece of strong evidence that amyloid must be involved in Alzheimer's disease and may even be involved just in normal cognitive decline. So then let's talk about biomarkers just very briefly. Researchers have been looking at this for decades now. And if you look at certain biomarkers over time, here and graph it out, here's what you see. So this first curve, it's in red, is the formation of A beta, beta amyloid. And this starts accumulating 15 to 20 years before we ever develop any cognitive changes. So we see that first. Then this blue line is tau-mediated injury, so neurofibrillary tangles. So we're saying first we develop plaques, Then we develop tangles. And then the green line is structure atrophy. We start having atrophy. And then it's very far down here that we start developing memory problems. So that's, again, evidence that 15 to 20 years before we develop problems, first we start developing amyloid and then tangles and on down that list. So from 3 different areas, we've got a lot of reason to think amyloid plays an important role. So if we accept that is true, what can we do about this? And that's where anti-amyloid therapies come into play. And a lot of strategies have been used over time. So one strategy, which I thought was a great idea, was to reduce the production of beta amyloid in the first place. If we don't produce beta amyloid, is it possible we prevent the progression of Alzheimer's disease altogether? So those are secretase inhibitors. What if we could block that enzyme, beta secretase? It is a good idea, but we have not yet developed a drug that does that and actually makes a difference or doesn't have significant side effects. So it's a good idea, we failed. Well, the second idea was anti-aggregants. What if we just block the clumping together of beta amyloid? We keep that sort of dissolved in the fluid around the brain and clear it out more effectively. Good idea, again, has not worked. And then what we'll focus on the rest of the time are immunologic therapies. And as just a little bit of history, this dates back to 1999 when Schenck and a group of researchers showed that they could take mice, they're called transgenic mice, mice that have been engineered to develop Alzheimer's disease, and they vaccinated them against A beta or beta amyloid. And when they vaccinated these mice, they actually showed some reversal of their cognitive impairment. And just in general, these mice did better. So the idea was we can use our own immune system to clear out that amyloid, and then maybe we'll do better. So that was very exciting at the time. We tried that in people, and it was not very effective, and in fact led to inflammation in the brain of some people. It caused an encephalitis. So vaccinating people, maybe not a good idea, but still, is there a way to use the immune system to help clear out amyloid? So we'll talk about that more over time. So some of the failures, most of my life has been spent doing research trials and seeing them fail. So we had trials of different secretase inhibitors, they failed. We had several trials of monoclonal antibodies created in the laboratory against amyloid. The idea being we now piggyback on the immune system, we clear amyloid out of the brain. Bapineuzumab, gantenerumab, solanezumab, and all of these failed. So we weren't doing very well until finally a medication called aducanumab or Aduhelm maybe was effective. It received a expedited, I believe that's the term, approval in June of 2021. And the approval, interestingly enough, wasn't to treat Alzheimer's disease as much as it was to remove amyloid. The trials did prove that it removed amyloid. They updated the approval a month later to say, well, this is really for mild cognitive impairment or mild Alzheimer's disease. But there were problems with it. No one was ever really, well, I shouldn't say no one, but the field was not convinced that it was clinically effective. The initial trials were stopped because they were found to be ineffective. And then later, the company looked at the trials and said, well, maybe we shouldn't have stopped them. Maybe it really was effective. So there's a lot of controversy around this. And ultimately, earlier this year, January 2024, Biogen announced that it was discontinuing sales of this medication. So we had a hopeful sign, but that really didn't lead us where we wanted to be. Well, we got better news in January of 2023 with lecanemab, the trade name for that being Leqembi. So it received an accelerated approval by the FDA. And that accelerated approval was, again, based on the idea that it effectively removes amyloid from the brain. And the FDA then said, well, if it removes amyloid from the brain, there is good reason to think that it will slow the progression of Alzheimer's disease. And then with further evidence in July of 2023, the FDA gave it full approval, stating, well, now we see the evidence that this really is effective clinically in Alzheimer's disease. So July 6, 2023, that announcement was made. Caught a lot of us, at least myself, off guard that CMS, the administrators of Medicare, also said at the same time, we will provide coverage for this. So that was a pretty big deal. And a couple months later, 2.5 months later, the first individuals in the state of Kentucky began treatment with this medication through our facility. So let's talk about lecanemab. Why was it approved? It is a monoclonal antibody, meaning it's an antibody created in the laboratory that has high affinity for amyloid beta protofibrils, A-beta protofibrils. What does that mean? It means these antibodies bind to, very effectively, beta amyloid where it is just starting to stick together, theoretically just before it starts forming plaques themselves. And the approval came from a 1.5 year long study called Clarity AD. It was a double-blind placebo-controlled trial. What that means is people enrolled in this trial and were randomly assigned to either receiving the medication or receiving a placebo. And the participants were blinded, the investigators were blinded until after the study was over with. And that's done so that we can effectively determine, are people benefiting from the medication or not? Believe it or not, it is not uncommon for people on placebo to show some improvement in these trials. And that's great, but you want to really see, is it a difference with the medication or not? And the people that received this medication received it by an intravenous infusion, intravenously, every 2 weeks for the duration of the trial. And the first thing you see is what happens to amyloid. So this is looking at a PET scan. A PET scan is one way to measure the amount of amyloid in the brain. And the blue bar there is showing us people that were on placebo may have gotten a little bit more amyloid over the course of the trial, but essentially didn't change. People on the treatment had a fairly dramatic reduction in their amyloid. That's that falling sort of gold line here. So that by the end of the trial, many of the people you would actually say they are now amyloid negative. We do not see amyloid in their brains to a significant degree on a PET scan. So very clearly, it does what it's designed to do. It removes amyloid. But what does that mean? Is that effective? Well, this is a different graph looking at a scale called the CDR, Clinical Dementia Rating Scale. And what it's trying to do is measure cognition and just overall function. And you naturally see a decline on that scale. What you want to see is less decline if you're on treatment. And that's exactly what you see. So the blue bar people that were on placebo were not on treatment, and you saw a decline over time. You still see that decline on people that were receiving lecanemab, but you see a lesser degree of decline. And you see that over the course of the treatment, that separation between treatment and not treatment was getting wider, which is exactly what you want to see. Now, ideally, you'd like to see no decline, but what you're at least hoping to see is that it slows down that decline. And that's what you saw in that measure. Here's another measure looking at ADLs, activities of daily living, just our normal day-to-day activities, dressing, bathing, preparing meals, etc. And you see the same thing. You see a decline over time if you're on placebo. You see that decline on lecanemab, but you see less decline. So again, on two important measures, people seem to do better if they were receiving lecanemab than if they were not. And if you look at all of the different measures there, you see various changes. On one measure, the reduction in decline was as low as 23%. On one, it was as high as 36%. The main measure was 27%. But when you put all that together, what we typically will tell people is that this medication is not going to reverse memory loss. It's not a cure. It's not the cure we want, but it slows progression by about 30%. And that's a pretty fair statement, I think. So what about side effects? That's important to know about. If you look at the total number of AEs, these are adverse events, side effects, you might be struck at first by the very high number here, 88.9% on people receiving. So let's say 89% on people receiving treatment, lecanemab. But you also saw 82% in people on placebo. What you're really looking at is the difference there. If you ask me to keep a diary of every symptom I have over the next 18 months, the odds are very high that one day I feel dizzy. The next day I might feel nauseous. The next day I might feel pretty good. What you need to do is be able to look for a difference between people that were getting the medication and on placebo. And actually, when you look at those, you would come to the conclusion that this is a pretty well-tolerated medication. There's not a big difference between people on treatment and not treatment. But there are a few things that are important. So first of all, we always look at death. Now, I'd like no one to ever die, but the truth is, over a course of 18 months, some people are going to die. In the actual study, 7 people on placebo died, 8.8%, 6% of people on treatment, 0.7% died. And you would look at that and say, well, it does not look like there is an increased risk of death. And that would be true. It should be pointed out that after the study was completed, 2 people that were on treatment did die, and it was thought that that could have been related to treatment. These were people that were receiving either very strong blood thinners or received a what I would call a clot-busting medication for stroke, and they had catastrophic bleeding complications. And because of that, we now recommend that people on strong blood thinners don't receive this medication, and we recommend that people on this medication don't receive that particular clot-busting medication for stroke. In the future, we may decide that's not necessary. In the study, that was not necessary. But because this is a fairly new medication, out of abundance of caution, we want to be very careful. Now, I know I'm digging into this a little too heavily, perhaps. These are the most important things I tend to talk to people about. First of all, infusion reactions. About a quarter of people receiving this medication in the trial had an infusion reaction, feeling achy or tired or headachy, nauseous, something like that. Those tended to be very mild. Those tended to go away. And if we pre-medicate people with this medication or receiving these medications, that tends to prevent subsequent infusion reactions. And our experience has been consistent with this. That has not been a major problem for us. This next one's the one that I think is more important, ARIA. That stands for amyloid-related imaging abnormality. And what it really boils down to is swelling or bleeding in the brain. Now, that potentially sounds pretty scary. And if you look at this first number, that's really scary. Over 1 out of 5, or about 1 out of every 5 people receiving this medication have some degree of ARIA, some degree of swelling or bleeding in the brain. And that's serious. The good news is the great majority of those people have no symptoms. And most of those people, it just simply goes away on its own. It's only about 3% that actually have symptoms of ARIA. And this is what that might look like. So if you look in this top panel here, B, where those arrows are, that's showing us a little bit of swelling. That's called ARIA-E. E is for edema. In this bottom panel, those little black dots are microhemorrhages, little microscopic areas of bleeding that's ARIA-H. So that when we do very frequent MRIs, as we do with these medications, we're looking for signs of swelling or bleeding that might tell us to stop this medication or at least to monitor it very carefully. Now, if we look a little more closely, so again, if we're looking at ARIA overall, it's about 21% of people that have some degree of ARIA. If we're just looking at the swelling, about 12.5% will have that. 90% of the time, it's mild or moderate. Almost 80%, 78% of the time, there are no symptoms. Most of that occurs in the first 3 to 4 months, and most of the time it resolves on its own. Just under 3% of everyone treated will have symptoms of that. ARIA-H, which means hemorrhage or bleeding, typically is going to be associated with E. There were 5, less than 1% in the whole group in the trial that had macrohemorrhages. These mean not microscopic, larger areas of bleeding versus only 1 in the placebo group. So we really watch for that very carefully. We hope never to see it, but we know in some percentage of the cases, people are going to have bleeding complications. We want to really watch for that. The symptoms that somebody might have, headache, confusion, changes in vision, dizziness, nausea, maybe trouble with walking. If it's very serious, less than 1% of the time, we expect this to be serious enough someone would have to go into the hospital. We worry about things like seizure, encephalopathy, just our fancy way of saying confusion or stupor. They may have signs that look like stroke, that mimic stroke. So we have not seen that yet, but we want to watch for that carefully. So I've told you what's good. I've told you what the potential side effects are. What are the appropriate guidelines? So to be eligible, someone needs to have mild cognitive impairment due to Alzheimer's disease pathologically, or have mild Alzheimer's disease. Essentially, I could take that to say mild memory loss, and we see the presence of amyloid on some test that we might do. I know it sounds silly to say, but I say it every day. There would be no reason to use a medication to remove amyloid if there's not amyloid in the brain. So when we say pathologically, we mean we detect the evidence of amyloid. Need to have a mini mental state exam. This is a standard memory test that we do in the clinic of 22 or above. Again, that just means the memory loss is relatively mild. It's recommended an age range of 50 to 90. We have made an exception on one occasion there, but generally 50 to 90 is a pretty good range. Again, I already said this, we need to see the evidence of amyloid. We are typically measuring that by a spinal fluid exam right now. I expect in the future we may be doing PET scans more often. That's a little bit like a CAT scan, but it can detect the evidence of amyloid there. Let's see. Well, what are some of the reasons that we would not do it? One of the most important is the inability to have an MRI. We have to do the MRI to look for any problems that would tell us someone's at a high risk for bleeding complications, but we also have to do repeated MRIs during those first few months of treatment to carefully look for any problems. There's something called CA, amyloid angiopathy. If someone has amyloid angiopathy, that's a vascular disease, will often look like Alzheimer's disease, but the concern is not only is that a different condition, but that may put someone at very high risk for bleeding complications. So those are things we might see on an MRI. And then areas of significant vascular disease. Lacunar strokes are very small strokes that many of us may have without knowing it, but if we have a large number, that may be telling us we've got the wrong diagnosis. If someone's had a large stroke, again, may be telling us we've got the wrong diagnosis, but also may be telling us that we might be at high risk for complications. So we look for those things on an MRI that tell us we should not proceed with this medication. If someone is on a strong anticoagulant, a blood thinner like Coumadin, warfarin, Eliquis, Xarelto, we may change that recommendation in the future, but we try not to use this medication in that case. If someone's had a stroke, if someone's on certain immunosuppressant medications or monoclonal antibodies, again, I think some of those requirements may change in the future, but right now we're being very strict with such a new medication. Seizures, other medical conditions. I won't read through all of those. Point is, there are a number of things that we look at, and so we end up with really, unfortunately, only a minority of people that are eligible for this medication. If we've gone through all of that, this is an infusion. It's received every 2 weeks. The infusion itself takes about an hour. After the first infusion, we observe people for about 3 hours, watching for any infusion reactions. With the second one, we watch people for about 2 hours. After that, it's only about 30 minutes. Again, we're watching for any infusion reactions, and we have seen some of those with the first or second infusion. It's not tended to be a big deal beyond that. I mentioned we have to do frequent MRIs. We do MRIs before the 5th, the 7th, the 14th infusions. And in some cases, we may do an MRI at the 1 year point as well. If someone has evidence of ARIA, swelling or bleeding, then we may or may not continue the medication, but at that point, we do require that we do an MRI once a month. Again, just watching very carefully for any progression. We're doing our best to avoid any serious side effects down the road. This is sort of quotes from experts, and I think this holds pretty well. In most cases, ARIA, swelling or bleeding, is asymptomatic, no symptoms. Few cases are going to be serious. And yes, we think very rarely there will be cases where that is fatal. I don't tell people that to scare them, but to be very upfront about that. In the trial, about 21% of people had some degree of ARIA, but it was just under 3% where that was symptomatic. We'd strongly recommend doing a blood test, looking at a gene, ApoE, we talked about that earlier, that can help us define that risk a little bit more carefully. So if someone has, for instance, no copies of the E4 allele, then their risk of having symptoms related to ARIA is low as 1.5%. They have one copy, about the same, 1.7%. But if they have 2 copies, the risk of having symptoms related to ARIA is just over 9%. And there are some centers around the country who will not use this medication if someone has 2 copies of the E4 allele. Many will, and we allow it, but we just want to be very upfront with people what exactly those risks are so people can make that determination themselves. If somebody does have ARIA, swelling or bleeding, if it's mild on the MRI and they're not having symptoms, we just continue and watch very carefully on monthly MRIs. If it's more severe than that, if it's moderate, it's severe, they have symptoms, then we will stop treatment. We'll watch MRIs carefully. And we have had all of these play out where the MRI looked better, we resumed treatment. We've had 1 or 2 people where they have made the decision themselves not to restart treatment, and that's reasonable. If somebody has severe ARIA, really having severe symptoms, need to go to the emergency room, we need to do an MRI, and may need to be admitted to the hospital and get a steroid. This is thought to be an autoimmune reaction, kind of an inflammatory reaction in the brain. And so we can treat that with steroids. We have not been faced with this issue ourselves, but we've been faced with similar type of issues. And I've seen this respond very well to steroids. Now, I think I don't have a whole lot of time left, but I want to say a couple of other things, looking more towards the future. So there's a meeting this last fall, it's held every year. It's called Clinical Trials in Alzheimer's Disease, or CTAD. And Eisai, the company that makes lecanemab, presented data on a subcutaneous form of this. It's essentially a form that then we could give ourselves injections of it at home. And the data looked very, very good. And so the hope is in the coming months, and we don't know when, but hopefully in the coming months, the FDA will review and approve that formulation. So it still involves an injection, but it may save people the trouble of having to come to an infusion center. So we are excited about that. We don't know when that's going to come. And then they also showed what are called open label extension studies. So their original study was just for a year and a half. But then after that year and a half, people were allowed to continue on the medication, and those that were on placebo even might have been allowed to be on treatment. But the point is, when you looked at those open label extension studies, it looked like the gap between placebo treated or untreated essentially and those treated with lecanemab continues to widen. So it at least gives us hope that the benefit of medications like this are going to be even greater over time than what those initial studies showed us. So some reason for optimism there. Now, this is just telling me to pause and pivot to the next one. I want to say just a few things briefly about donanemab. That's another medicine similar to lecanemab. It's an antibody that removes amyloid from the brain. It is currently under FDA review. Frankly, we all thought that it would have been approved by now. About a month ago, the FDA announced that they were going to have a review, an advisory panel, look at all the data to help advise them on whether to approve this or not. It was a little bit of a surprise move, but I think the thought is the data looks so good, this will almost certainly be approved and on the market. It's only a matter of time when. So I think it's worth just saying a few things about it. The original article was published almost a year ago in one of our major journals. It was a trial called the Trailblazer ALTS 2 trial. And one of the reasons it might be hung up at the FDA is it was a pretty novel designed trial. And this, don't get caught in all the details there. This is more to remind me to talk about it. So in their enrollment, they're looking at people between the age of 60 to 85 with mild impairment. So again, mild cognitive impairment or mild Alzheimer's disease. But in this case, they required people not just to show evidence of amyloid, but you also had to show evidence of tau, another part of the pathology in Alzheimer's disease, using two different types of PET scans. The other criteria is similar to what we saw with lecanemab, essentially ruling out amyloid angiopathy. And then they said, okay, well, we want to see tau, and our real target are people that have relatively low amounts of tau in their brain, but it's okay. We're going to look at people that have low and high tau, but they look at their the outcomes divided up between those two groups. Now, the take-home message from this is what I think is going to be part of a continued move towards further and further refining who is our ideal target for these medications. We saw something similar to this in the stroke world, and as we can refine this more and more, the actual benefit seems to be greater and greater, that we're doing a better job of defining who and when people will most benefit from these medications. And then the other unique part of this, again, don't get hung up on this slide, but people were treated with donanemab or placebo. That's a requirement of the study. But of the people that were getting the medication, they kept having PET scans. And when they went to amyloid negative, they were taken off drug and put on placebo. So in other words, the idea was, all right, we're going to treat, but we think all we need to do is get rid of amyloid. Once we've gotten to that point, you don't need to be on this treatment anymore. And that was pretty unique. And I think that may be giving the FDA some trouble. A large number of patients then were eventually converted to placebo because this medication is highly effective at removing amyloid over that 12 to 18 month period. And then this is just looking at the different outcome measures that they used. We'll talk about that as we get into it. So their primary outcome measure is something that's sometimes called IDRIS. Don't worry about that. It's just a composite measure that looks at cognition and function. And so the idea is similar to what we saw with lecanemab. We want to see the people on treatment decline less than the people on treatment. And if you look at the low tau population on placebo, that gray bar, they're declining at this rate. The green bar is on treatment. And you see actually very early on, you start to separate. Then you may have to take my word for it, but that separation continues to widen every time they look at it. So on this, if you look at the low tau group, it slowed things down by about 35%. If you look at everybody that was in the trial, it was still good, but only about a 22% slowing there. If you look at the CDR, and I show this because that's the one measure that they have in common with the lecanemab trial. If you look at their low tau group, or low to medium tau group, it slows it down by about 36%. That's a good number compared to 27% in lecanemab. If you look at everybody, all comers, it was about 29%. That's more similar to what you saw in the lecanemab group. And what I take from that is the earlier you start this medication, the more effective it's likely to be. And then this is showing us that even after people went on to placebo, so let's say I received this medication and at 12 months, I now am amyloid free. You take me off the drug, but you continue to follow me for 6 months. I continue to do better than if I weren't on treatment, and that difference continues to widen. You really see that effectively in this graph over to the right-hand side. So Lilly would argue this is proof that the benefit continues even after we stop treatment. This is, to me, really, we're getting into too small numbers to make too great a conclusion here, but it gives me a lot of optimism for the future. Now we're really refining that population. We are taking people with mild cognitive impairment. They have amyloid and tau, so we think the underlying disease is Alzheimer's disease, but mild cognitive impairment, so we're at that mild end of the range, and we're saying they have low to medium tau. So we're really honing in on that group that is at the very, very mild end. And now look at this. If you look at the IDRIS, we're slowing progression by 60%. That is a mind-boggling number for somebody like me. If you look at the CDR, 46%, so almost 50%. And you look at how those curves continue to widen. So this isn't good enough to really say we've got firm conclusions, but that is extremely encouraging to me for the future, that as we continue to develop these medications and we target people appropriately, we might really start to see some exciting results here. So just a few conclusions, and I promise I'm getting to the end here. So this is donanemab, looking at some of their outcomes they were looking at, 47% of people on treatment saw no decline on the one measure, the CDR, at 1 year. Now, to be fair, 29%, 30%, almost 30% of people on placebo also saw no decline. So not everyone declines within that year on that score, but still close to 50% on treatment, you saw no decline. I think that's a big deal. Most people, or just over 50%, completed their course of treatment at 1 year, meaning they were amyloid negative at 1 year. 72% were amyloid negative at 1.5 years. So it's effectively getting rid of amyloid. And in this particular case, they were able to stop treatment. People on treatment had 40% less decline in their ability to perform their day-to-day activities of daily living. And then the other number I do like here is 39% lower risk of progressing to the next stage of disease. So it really did slow progression, not just in terms of some abstract number, but in terms of progressing to next stage of disease. So I think that's pretty exciting. What about risk for it? And there was a higher risk for it. So about 24% of people on donanemab experienced ARIA-E, that edema. That's really about twice what we saw with lecanemab. And then if you look at ARIA, just look at this panel on the, or section on the right-hand side. If you take 100 people, 24% had ARIA-E, about 6% had ARIA-E or hemorrhage. So those are bigger numbers, and people have to be aware of that. So if we kind of take the bottom line here, donanemab, it looks exciting. Treatment can be stopped with it, according to their study. That's exciting. Efficacy, the progression was clearly slowed, and that benefit continues to accrue even months after stopping treatment. Benefits potentially very high if started very, very early. But risk of ARIA, over a third of all people had some degree of ARIA, edema or hemorrhage. And in this case, 6.1% had symptomatic ARIA. So if we compare that, we'll compare that back in a minute. It's difficult to compare them two directly. These were two different studies, different populations, slightly different enrollment criteria, slightly different outcome measures. But if we do try to compare them, we can on a couple of measures. The CDR was used in both cases. In lecanemab, slowing was 27%. Donanemab, it was 29%. To me, that tells me that the benefit is probably similar with these two medications. If you look at ARIA, this is clearly higher in donanemab. And the number I look at is symptomatic ARIA. And I look at this to say, well, about 3% on lecanemab have symptoms of ARIA. About 6% of people on lecanemab have symptoms of ARIA. So you might argue that's still a relatively low number, but it's about twice in donanemab. If you look at by ApoE status, I don't have all the numbers to fill out this chart, but we could say that, you know, clearly those numbers seem to be higher. About 40% if they have two copies of the ApoE allele will have some degree of ARIA. I don't know what that symptomatic number is, but you might speculate it's significantly higher than 9.2%. We don't know that. But I think it's fair to say the risks seem to be higher with donanemab. The infusions with lecanemab, it's every 2 weeks. With donanemab, it's every 4 weeks. That's a clear advantage for donanemab. Duration of treatment, right now, we tell people with lecanemab, we don't know. It may be forever. It may be till you transition to a moderate stage. I wonder if in the future we will look to see if people on lecanemab become amyloid negative by PET scan and stop treatment. But the truth is we don't know that. With donanemab, it seems likely that it would be time limited, somewhere between 12 to 24 months. We'll see what the FDA says about that. I know that was a lot of information to send out. In summary, anti-amyloid agents have arrived, and it is not the cure, but it is a big deal in our field. I think it is going to meaningfully change the trajectory of this illness and really help people. These medications slow progression, especially when started early. And I think we're going to learn more and more. The earlier, the better. Maybe not exactly the same as with stroke, but to some degree, it will be true here as well. Time is brain. Right now, it's an intravenous, it's an IV infusion, but the subcutaneous formulations where you might be able to do an auto injector at home, they're being developed. I think they're coming. ARIA, swelling, bleeding, that's the most important adverse event side effect, and we have to look for that very closely. One more slide. So this is what the progression looks like. So the dotted blue line is what it looked like when I first started my career. The yellow line is when we start developing medications like donepezil or Aricept or ivostigmine or Exelon. We moved that curve over a little bit. We delayed disability a little bit. The solid blue line is when we developed memantine or Namenda. We moved that curve over a little bit more. Didn't cure it, but we managed the disease a little bit better. And then this gray line is the development of these anti-amyloid antibodies. And what I believe that is going to do is push that line even further. It's not the cure, it's not reversing it, but it's allowing us to manage this condition more effectively longer. It's allowing people to be more capable longer. So that really is the last slide. I appreciate all of you all for your time and sticking with me. And I think we've got some time left. If anyone has any questions, I'm very happy to answer those. Take it any direction that you like.
Yeah, so just a couple questions came in, and I'm glad you ended with that slide because that was the comment I was going to make. Every time I hear information about lecanemab, it has to be impactful or meaningful to you to see when you started your career to where we are now. I mean, yes, you know, we would have wanted something sooner, but at least we have something now. But hopefully the future is looking much brighter with this this new treatment, possible treatments available. So very nice to see. So can you explain accelerated approval? You mentioned accelerated approval with this drug. Can you explain what that means?
So that's been around for a while. It became very controversial with aducanumab. What it means is the FDA can approve a treatment, a medication, that has not shown clinical benefit yet, but it shows a change on some kind of biomarker, a blood test, a scan, whatever you like, that the FDA believes is reasonably likely to translate into a clinical benefit down the road. So that's been important in the oncology, the cancer world up till now. And so they used that format for aducanumab. They said, well, you have not shown that it provides clinical benefit convincingly, but you did show it removed amyloid, and we think that is enough. And again, that was very controversial. A lot of people resigned from their advisory panel over that. And you could make the argument aducanumab studies were stopped based on a futility analysis. The company didn't even complete the study because they had an independent board that said there's no real possibility that this medication is going to be effective. They stopped the trial. And then it felt a little bit odd when they went back and said, well, you know, that panel was wrong. The drug actually did work. So it created a lot of controversy. The idea that the FDA has is not necessarily a bad one. There are other conditions in neurology that were approved based on that accelerated approval. And then later on, the studies came out that showed that was a good idea. It really did provide clinical benefit. It's a mechanism to get treatments in badly needed conditions for conditions that badly need treatment there earlier. But it became highly controversial because of aducanumab. That was more than anybody asked for. I realize. Hopefully that helps.
No, but that was well explained. Yeah. Are you involved or aware of targeted MRI treatments for Alzheimer's?
So I wonder if what they mean are targeted or focused ultrasound. And I am a little bit aware of that one. There's an idea got popularized, and a lot of people may have seen this on 60 Minutes. Let me even back up from that a second. There is a treatment called focused ultrasound, which we are going to be using at our center in the future, but it has been used to create actually a lesion. It's as if it burns a tiny little area deep in the brain that can, by doing that, can treat conditions like tremor or Parkinson's disease. So that's been around for a little while, not real long. And that is a very effective treatment, and it's a relatively non-invasive treatment. It doesn't involve cutting open the skull. Well, so recently, investigators decided to try this to see if they could break down what's called the blood-brain barrier. So we have membranes around our brain that are protecting the brain from essentially the rest of our body, and that's a good thing. But the problem with that, it's hard to get drugs past that barrier into the brain to treat conditions within the brain. So if we use this focused ultrasound, we can temporarily knock down that blood-brain barrier. So now drugs can get into the brain more effectively, and so maybe they can treat these conditions more effectively. And that does make a lot of sense. There are very preliminary trials. I believe it looked at 3 patients that had this, and it was essentially a proof of concept sort of study. They showed that they were able to deliver what they think was a more effective dose of the drug into the brain. So that was pretty neat. But that's as far as it's gone so far. So that we are at the very, very cutting edge of that. We may hear more about that in the future, but it's not clear yet where that will go.
Thank you. What would you suggest to a caregiver who is showing the line between respecting a patient's wishes to do nothing and hope for the best versus getting assessed to possibly be a candidate for the new medications that are being discussed? The
So
patient does not believe anything is going on
yeah, that is
or aware of the issue.
a great question. I will give my answer. Maybe someone else here will have a better answer. I think it's a really hard one. One of the tenets of medical ethics is sort of autonomy. People should have the right to make their own decisions. As long as I'm competent, you shouldn't be able to inflict your opinions on me, even if you think I'm making a bad decision. So I think that is true. And it is also true, people with mild cognitive impairment and even mild Alzheimer's disease very arguably are competent to make their own decisions. And so we do have to respect that. That is true. At the same time, we have to balance the fact that depending on the level of disease, their competence may not be perfectly normal. So it's not a black and white line. It's more of a gradient there. And we have to be cognizant of the fact that these medications may be effective in this window, and later on they may not be effective. So all I'm outlining is the problem that you're facing. I understand that. I think the best strategy I use now is to try to be as non-judgmental as possible. I try not to be too pushy. I lay out the facts. I maybe explore the reasons why someone would or would not want a treatment, not as a way of me trying to inflict my own opinions on them. I don't think it should be my personal decision, but I try to understand what they're afraid of. Or afraid is probably not the right word, but do you know what I mean? And then sometimes the answer will be, well, they don't want the drug because they didn't understand what I said. They may have fears that are not grounded in reality. And so we have to continue that discussion, and we make sure they understand it. And in some cases, when we make sure they understand it all, they change their mind. They want the treatment. In some cases, it's a matter of making sure both they and their family understand it, and they need to continue that decision as a family. And in some cases, I may myself make a decision that maybe I don't want to do, but I'm going to do it for my family. That's okay. I don't think there's anything wrong with that. So that may be one strategy. In some cases, it may be that the individual, the patient, has very good reasons for not wanting the treatment that the family didn't understand. And after you have that discussion, well, it still may not be a decision the family would make, but at least you understand it better. So that's a very long-winded way of saying I think it requires a very thorough discussion and exploration of what are the reasons. We need to try to understand what that individual's reasons are. If it's based on faulty information, we need to correct that. And if it's a very well thought out reason, we may have to respect that. So that's my answer. Can you all give a better answer, maybe?
I
I
think
mean,
that
you
was
said it's
perfect.
long-winded, but I don't see, oh yeah, I was gonna say, I don't see any other way to answer some of those questions, because sometimes that's exactly what you have to do in dementia care when ethics and things are involved. You have to talk it out. I don't think it was long-winded. I think it's just, you have to think through all the aspects that are, all the variables. But yeah, Aaron, go ahead.
Oh no, I think that was a perfect answer. The only thing I would say is it sounds like in that question at the end that the person wasn't, I don't know if they have a diagnosis. So that would be a good first step, because depending on their diagnosis, this may not even be in that framework. So making sure that you get a proper diagnosis would be a good first start to start those conversations as well.
That's a
Or
really
I
good
took
point.
that last part as the patient might not be aware. So that's where this fancy word of, is it anosognosia, comes into play, where they don't understand what their diagnosis is. They're unaware that they have this diagnosis. So lean onto your support staff, have these conversations with your medical provider, contact somebody at the Alzheimer's Association or our social workers at Norton. And this is exactly the conversations that we want to help and support you with. So great question.
Let me add one other thing there, which
Mhm.
you can argue. I don't mean this to sound deceptive. I think it's honest, but it could probably be seen that way. If someone really doesn't believe they have much of a problem, which is common, the truth is, if I have memory problems, I will probably not realize it and will deny it. You can look at medications like this, if it's really something the family is supportive of, as preventative. We are trying to prevent greater disability in the future. So instead of trying to beat someone over the head and shoulders that you have Alzheimer's disease, you need this drug, you can say, look, we see some evidence of mild memory problems, and what we're trying to do is prevent or delay more serious problems down the road. I don't think that's really a dishonest way of looking at it.
No, that's a good point. Very good point. One more question, and then we'll wrap up here. Could these therapies that you've been mentioning be used for other forms of dementia in the future?
So the anti-amyloid therapies, actually, no. Everything we've had up till now, well, it may be approved for Alzheimer's disease, are highly non-specific. This one is actually highly specific. It only works against amyloid, which is the pathological underpinning of Alzheimer's disease. So the short answer is just mild cognitive impairment due to Alzheimer's disease or Alzheimer's disease.
Great. Okay. Any closing words, Dr. Cooper or Aaron? We wrap up.
My only one would be thank you for sticking through a thick and murky talk. But it's I would want people to leave with some real optimism. I look forward to a few years from now saying, do you remember how bad medicines like lecanemab were and how great it is now? I really am optimistic we are on the threshold of a new era. And I think it's exciting for the first time in my career. It's exciting that we are really starting to make some major headway. So I hope people are left with a sense of optimism for the future.
Absolutely. And also just knowing as a caregiver that you're not alone. Sometimes it's hard to ask for help, but we are here to support you as a caregiver and your loved ones. So just making sure that you're getting those resources, you're finding those programs, you're learning more about the different stages of the disease, or, how to talk to your doctor about this medicine. Those are all options that make sure that you're utilizing, and know that you're not alone, and we're here to support you any way we can.
Awesome. Thank you all. So join us next time for the second part of our 3-part series. So what is a caregiver's risk of developing dementia? So that it will be, again, with Aaron with the Alzheimer's Association, and one of our other memory specialists, Jessica Kane, will be joining us. So feel free to please register, share it when you get that email, or on Facebook, you see it there. And we will follow up with an email to you guys just with some additional resources that Aaron mentioned also. and never hesitate to reach out to any of us if you need anything. Thank you for joining us today.
Thank you.
Thank you all.